Good evening, one and all. On behalf of Rajkot Ophthalmic Society, I would like to welcome you all in this glaucoma meet. Our today's session will be of two talks. One of our own Dr. Piyush Jansari sir. He will be owning the session. After that, there will be some discussion. We have our guest speaker, Dr. Paaraj Dave from Baroda. Welcome, Dr. Paaraj, on behalf of Rajkot Ophthalmic Society. After that, there will be as per our tradition, there will be a felicitation of our very senior doctor, Dr. Bharat Shah. So we'll start the session with Dr. Jansari. Over to you, sir.
As Dr. Piyush Jansari shares his screen, there is not much to introduce Dr. Piyush. He is the only glaucoma specialist, or the first glaucoma specialist in this region, and has been doing good work in glaucoma for past many years, more than a decade or so now, I think. He's been trained at LVP Eye Institute. He has a full glaucoma fellowship from there, and he's been doing good specialist work in glaucoma. Yes, Piyush, you can take over.
Thank you, Mukesh sir, and thank you, Suketu. I thank ROS for this opportunity to talk in this COVID times. Initially, this was meant for, as I told, for the students and the periphery doctors. So it was basics of glaucoma. So I'll stick to it, and maybe sometime later we can do something more on this. So in glaucoma, I'm going to speak on basics of glaucoma, which will consist of four things. The first is intraocular pressure. We have to check the intraocular pressure of all the patients who visits for eye checkup, whether they come for glaucoma or anything else, because most raised intraocular pressures are asymptomatic, and we will miss if we don't check the IOP. Coming to the tonometers, which we use every day, the most commonly used is NCT, non-contact tonometer. The advantages are obvious that it is a no-touch tonometer, and it can be done by a non-medical personnel, and it saves our time. The disadvantages are that it overestimates the pressures in higher IOP range, and the variations in the readings are much more than it should be. And also, it is uncomfortable to the eye of the patient because there is a jet of air which is going to hit the cornea, and it startles the patient. So that will give some errors in the reading. So my suggestion is, don't take NCT readings for diagnosis and medication decision. Better confirm with an applanation. The second tonometer commonly used is Sheard's tonometer. It depends on the ocular rigidity. So the readings are higher in hyperopes because the ocular rigidity is high, and the readings are lower in myopes because the ocular rigidity is low. So it's going to have some errors because of its principle of IOP measurement. We have plotted this chart. You can see the yellow line is GAT readings, and the corresponding eyes of the same patients are the Sheard's reading in red dots. You can see there is a lot of variation in the normal range and a lot of more variation in the higher range of IOP. So it is not indicated to use Sheard's IOP for IOP checkup. If you have any other option, please use other tonometers. The Sheard's is it indicates a certain range of IOP. TonoPen is a variable force tonometer. It is easy to use and handheld device. It has very good correlation in the normal range of IOP with GAT, but it overestimates in lower range and underestimates in the higher range. Its most common use is that it's useful when the Myers are not visible on GAT, like scarred corneas in post-PK or contact lens eyes, and even on pediatric patients who are not able to give GAT readings. The newly introduced tonometer is Rebound tonometer by Eye Care Finland. It has a small disposable probe which bounces back from the cornea, and the force is measured and gives the intraocular pressure reading. It does not need a topical anesthesia, is its USP. It's helpful in pediatric patient and is the only home tonometry available to us now. It has very good correlation with GAT in lower IOP, but it underestimates the intraocular pressure when the IOP is beyond 23 millimeters. The other flaw is that the effect of CCT is even more pronounced on this rebound tonometer as compared to GAT. So the errors of CCT will be more in the rebound tonometer. So my suggestion is to use the rebound tonometer, especially for pediatric patients. And when there is doubt, confirm it with applanation tonometer. Coming to GAP, which is gold standard tonometer and most reliable as of now, the GAT displaces only about 0.5 microliter of aqueous humor when we check versus 15 to 20 microliters by any other tonometer. Hence, it has a repeatability value better than others. Its readings are comparable to the readings obtained by other examiners. So we can have these patients checked anywhere else and will be reliable. It is well integrated in the examination algorithm over the slit lamp. Hence, it is comfortable to the examiner as well as the patient. Sometimes patients ask me, "Ke Sahib, olu pressure to check kari liyo?" Then I have to tell them that, oh, it's already been checked because you are sitting on the slit lamp. The procedure in short is put topical anesthetic solution in the eye, stain with fluorescent dye, use the blue filter, hold the lids apart, align the prism tip to the center of the cornea from outside, view the Myers from the left eyepiece of slit lamp, move the knob of tonometer to and fro to get the correct alignment of the inner Myers. This picture shows a bit not very clear, but if you can see very thin Myers, they are not aligned properly. They are aligned more inside. This is the picture which shows they are not aligned properly, but aligned from outside. This picture is a proper alignment in low magnification. You can see both the Myers are properly aligned inside. So this is the endpoint of applanation tonometry, and we can have the readings. The correction factor roughly is 1 millimeter is equivalent to 17 microns. So thicker the cornea than 250 microns, we are going to get a false high IOP on applanation tonometry, and thinner than 520 microns, we are going to get false low IOP. But please do not write CCT corrected IOP because there is no consensus on this matter. We have to consider that thinner corneas have little more risk of glaucoma damage because of the correction, as well as because the scleral rings are found to be thinner and more prone to disc damage. There is some variation in GAT readings ranging from 2 to 3 millimeter between two observations by the same observer or between two observers at the same time. So it can be corrected by taking 2 or 3 readings and taking the mean of the 3 readings as the right IOP. Patient has to look straight, and up gaze and convergence is going to give false high readings, and blinking, squeezing of the eye and voluntary widening is also going to give false high readings. These are the factors affecting the intraocular pressure. Valsalva manoeuvres with lifting heavy weight, inverted posture, aerobic exercise are good for IOP. Fluid intake will increase the IOP. Nicotine and caffeine will increase the IOP. Alcohol and cannabinoids will reduce it to some extent. Corticosteroid, we know it will increase. cholinergic drugs and topiramate increases by forward rotation of ciliary process. I'm not going in details. Coming to the gonioscopy, taking the time, shortage of time, I'm skipping some of the slides. Second is gonioscopy is integral part of glaucoma assessment. How can you decide the difference between open angle and angle closure glaucoma without doing a gonioscopy? So everyone should learn how to do gonioscopy. There is age-old debate between 3 mirror versus 4 mirror, which has not much value nowadays, but let us see how different they are. The 3 mirror lens has a concave surface, and when you put it over the cornea, there is a gap in between. So you need a coupling agent to have a good view. Once you put the coupling agent in the lens, it gets sucked up to the cornea and the lens doesn't move. So you will have a very good view because the lens is fixed over the eye. And this lens is said to be supposed to be learned by the beginner so that they can have a better view. Also, this is the lens which is used for the laser procedures of the angle. But it is a bit difficult as compared to mirror. So the 4-mirror lens is a flatter lens, and you don't need a coupling agent. It directly touches over the cornea. And once you can put the lens on the cornea and see 360 degrees of the angle without turning, because it has 4-mirror. Also, it is easy as compared to the 3-mirror because it's not cumbersome with viscoelastic substance and all. And my favorite because it can do indentation. So if you want to differentiate between synically closed angle and appositionally closed angle, you need an indentation gonio lens. So my suggestion is to use 4-mirror, and if you are not able to see the angle structures, start with 3 mirrors. So this is the angle structure. You can remember by the mnemonic. I can see the Schwalbe's line where I stands for iris root, C stands for ciliary body, S stands for scleral spur, T stands for trabecular meshwork, and Schwalbe's line. So roughly you can remember that if you can see the trabecular meshwork, the angle is open. If you cannot see the trabecular meshwork, the angle is closed. So you can go with this table. If you can see the scleral spur is visible, if yes, it is open angle. If no, then do gonioscopy and see if there is any synechia. If there is any synechia, the angle is closed, that is primary angle closer. If there is no synechia, see if the IOP is higher or normal. So if the IOP is normal, it's just a primary angle closer suspect, and if the IOP is higher, it's primary angle closer. Coming to YAG-PI decision, literature says that occludable angle needs the YAG-PI, but after so many years of glaucoma practice, I found some eyes respond in a paradoxical way by increasing the IOP after doing a YAG-PI. Substantial number of primary angle closure glaucoma patients in India have more mechanism than just a pupillary block. They are anteriorly rotated ciliary processes, thick peripheral iris, anterior insertion of iris, creeping angle closure. So these mechanisms are independent of pupillary block. So they will not respond to YAG-PI. My criteria of doing YAG-PI is in the eyes who has thin iris with typical iris Bombay type closure with many crypts suggesting that iris is thin in the periphery, and I avoid doing YAG-PI in eyes with anterior iris insertion and creeping angle closures. Other indications are acute angle closure eyes and their fellow eyes, and all those secondary pupillary blocks like pseudophakics. Coming to the disc examination. Evaluating disc is the key out of all the examinations done for glaucoma. It is always better to see the disc and evaluate rather than looking at the fundus picture. Direct binocular view of the disc is preferable in dilated pupil on slit lamp biomicroscope. It gives more information than any other sophisticated machine. Disc damage in glaucoma can be picked up by careful disc examination. For that, we need to look at the following things: the size of the disc, the cup size, the rim health, nerve fiber layer defect, and disc hemorrhages. The disc can be of the average size or smaller or larger than average. If the size is vertical size is less than 1.4 millimeter, it is a smaller disc. If it is more than 2 millimeter, it's a larger disc, and between is the average size disc. The slit lamp settings are very useful. If you can measure the disc vertical disc size with these settings, and you can put the slit beam vertically over the disc with 90, 78 or 60D and use these correction factors to find out the measurement of the disc. Coming to the cupping, the vertical cup disc ratio is to be measured, and it is given in percentage, and in more than 0.5% cupping of in the disc, it is considered to be glaucomatous and needs to be investigated. A difference of 0.2 cup between two eyes is also to be taken with suspicious. But cup size will always depend on the size of the disc. So you can see these three pictures of the disc which are normal, but because the discs are different in size, the cups inside are also of different in size. So a small size disc is having a small size cup, and large size disc is having a large size cup. So more important than cup is the rim of the disc, and it shows whether it is glaucomatous or not glaucomatous. So you have to look at three things, that is isn't rule of the rim, thinning of the rim or notching of the rim, and failure of the rim. The isn't rule means inferior superior, nasal, and temporal. Inferior rim should be thicker than superior rim, and nasal rim should be thicker than the temporal rim. This is an example of a localized thinning of the superior rim of the disc, and there is corresponding NFL defect. One more example of a large inferior notch in this disc. Coming to nerve fiber layer, there is corresponding nerve fiber layer defect along with the rim thinning, usually a wedge-shaped defect. It can be seen in a red-free picture. A normal NFL has a light, dark, light zone, and absence of this pattern indicates a generalized loss of nerve fiber layers. A wedge-shaped defect are the classical glaucomatous defects. This is the first picture shows typical shining nerve fiber layers, and the second picture shows a dull barren vessels around the disc, which shows a generalized RNFL loss around the disc. This is again a typical wedge-shaped nerve fiber layer defect, very much more pronounced on the red-free picture which we see. Disc hemorrhages are pathognomonic sign of disc damage in glaucoma. They appear in areas where nerve fibers are getting damaged, typically seen at the margin of the disc. The NFL defects will appear after and subsequently the disc hemorrhage and corresponding field defect will appear where the disc hemorrhage were visible. Look for disc hemorrhage in all glaucomatous cases at every visits. Again, a red-free view is ideal for identifying a disc hemorrhage. As a typical classical picture of disc hemorrhage and which disappeared in the follow-up visit after usually after 3 to 6 months. So I'll just I remember a patient who is middle-aged, a medical person who got a disc hemorrhage even after a successful reduction of IOP by TRAB, and his perimetry got progressed. I saw the patient recently, was operated in Ahmedabad. So the detection of disc hemorrhage requires careful examination. If you see a very subtle small disc hemorrhage, which are better visible by red-free pictures. Coming to perimetry quickly, glaucomatous visual field defects will follow the pattern of nerve fiber layer loss. An inferior glaucomatous field defect will give a superior nerve fiber layer, superior perimetry defect. If you see this disc carefully, there is thinning of the inferior rim, and I did the perimetry, which showed up a small superior nasal step, plus there was again a small inferior nasal step. I went again and saw the disc properly. I took a picture. You can see a very thin NFL defect on the superior part, which is more pronounced on red-free filter. So this is all corresponding field defect over the structural damage. My next slide is not coming up, I think. The other eye of this patient with an inferior field defect. Okay, I'm coming to the, okay, this is the other eye of the patient, which has an inferior field defect, superior field defect and an inferior rim thinning. This is the picture which is coming up, a red-free picture with the inferior NFL defect, a small superior NFL defect, corresponding field defects. Read the perimetry chart in 8 parts. The first part is the first part indicates the name of the patient and the basic stuff of the test, which you have to confirm with the patient. The second part shows the reliability criteria. The reliability criteria is the error is more than 15%, it should not be relied on and the test has to be repeated. The gray scale is good for looking grossly at the high false positive and high false negative. A high false negative will have a cloverleaf pattern, high false positive will have a wide scotoma. The total deviation plot is will show overall sinking of the visual field and the overall sinking of the generalized depression of the visual field. The pattern deviation plot will show a localized effect in the visual field. For example, this patient which has a localized defect, also some total deviation generalized effect. So there is overall sinking of hill plus there is a localized defect in the hill of vision. The zone 6 shows mean deviation derived from the total deviation plot and the pattern standard deviation derived from the pattern standard deviation probability plot. The 7th zone is glaucoma hemifield test, which shows comparison of the superior 5 with a mirror inferior hemifield 5 group of depressed points. The actual values are important at last when you want to compare the edge points and the points nearby the defect. Quickly, I'm going to come to a case discussion which came to me recently. This is a 58-year-old female complaint of headache, was seen by ophthalmologist, and with following details: the intraocular pressure of right eye was 27, left eye was 29. Without any treatment, and I don't know which tonometer, but most probably an NCT reading. The disc mentioned was 0.6 to 0.7 cupping the right and 0.7 to 0.8 in the left eye. It was referred for glaucoma assessment. Her BCVA with us was 6.6, corrected 0.75 sphere, and left eye 6.6 and N6. Anterior segment was essentially within normal limits in both eyes. The GAT of right eye was 22 and left eye was 20 without treatment. Gonioscopy, both eyes were 360-degree open till scleral spur. Perimetry was done and it showed me a lot of defect in the superior hemifield, which was less likely, I thought. And then I saw the disc. The pictures are taken by slit lamp, so not very clear. But it is the right eye disc with 0.5 to 0.6 cupping without thinning of the rim, and the left eye is 0.5 to 0.6 cupping without thinning of the rim or NFL defect. So I repeated the test. This test was done after 3 days. The test improved actually, but still there was scotoma. So I saw the patient after looking at the second test why the test is still having scotoma. So I saw in the camera the patient was actually lying down, and then I asked my technician. She said that patient was extremely weak. I don't know what was the reason, but she was not able to do the test and move. So if you see the arcuate scotoma in the second test, they are crossing the horizontal line, which are not a glaucomatous arcuate scotomas, they are ring scotomas. Then I looked the patient on slit lamp, and you can see the drooping of the upper lid kind of hampering the perimetry. So that is also a reason of superior scotoma on the perimetry. So we checked the CCT, which was also high. So right eye CCT was 566 micron and 565 in the left eye. Hence, the headache was due to uncorrected refractive error. The borderline intraocular pressure on NCT was due to thicker CCT, and this perimetry scotoma was due to the lid artifact and tiredness of the patient. I have advised the patient to make a new pair of glasses and follow up for IOP after 3 months. So thank you very much for the attention.
Nicely summarized. all the essential basic glaucoma points, Piyush.
Thank you,
Yes,
sir.
I know that 20-25 minutes is not a great time for covering all the aspects,
Right.
but you've put all the points in good lucid order. All right. I know many people would have some basic questions about glaucoma. For a routine practice, uh, I don't know how many would do a applanation tonometry, though I know it is ideal. But what is the second best? Would you advise a eye care tonometer or a non-contact tonometer?
So I think
If
eye care tonometer is better than non-contact because it's convenient. It can be used even on pediatric patients in a lying down position. Uh, though in higher range, it sometimes shows a bit less reading. But NCT always gives sometimes bizarre readings, and the patient keeps on moving the eye. So the principle is that the light reflected from the flattened cornea is giving the pressure, intensity of light. So I think the errors in NCT are more than other tonometers. So it is very convenient, but I think second option should be rebound.
right, and the accuracy of the rebound,
Is better than NCT.
right, and discomfort to the patient, they
The
can hardly
discomfort
feel it.
is hardly they can feel. Even children they are comfortable with the rebound tonometer. I don't have it one, but I have used for a few days over children as well as adults, and even on my eyes. But you don't feel actually the striking of that probe. Hardly we feel it. Before we realize it is actually
Done.
gone.
Right. Yeah, that's a good point because shear tonometer, I don't think anybody should use, and even maintaining that tonometer is a big thing. I would say it doesn't work most of the time. So that is good.
Piyush, I wanted to ask you, I presume you do intraocular pressure assessment before you do a gonioscopy. You use
Yeah.
fluorescein for the applanation tonometry. Do you have any procedure to wash off the fluorescein before you do gonio? Or it is
Uh,
all right, the fluorescein does not affect your examination of the
Angle.
Yeah,
angle?
it doesn't. It's a blessing in disguise, Harshal bhai, because the fluorescent. Otherwise, we will not check the cornea. But by doing IOP, we check the corneal surface,
That's a
and
good idea.
I usually wipe out the gonioscopy lens after doing each this thing with sterilium and then with a dry cotton. But I don't wash out
Sterilium from
the
Mhm.
yeah, yeah,
That is
this
what I
thing.
asked. Okay, okay.
I don't wash. Yeah,
And you use sterilium to clean the gonio
I
lens.
use.
Does it
Yeah, I
not affect
use
the
steril. Yeah, but I use
optical
sterilium
coating?
and then I. No, it doesn't. Up till now, no issues.
Acha, okay, okay, okay. Thanks, Piyush.
Thank you, Arshal bhai.
Right. And the other point, you talked extensively about perimetry as well as the disc assessment. What is your thinking on the role of OCT, retinal nerve fiber analysis?
Yeah, all this the three machines actually. OCT is coming up better. I think Paaraj will talk more on that. But OCT is good for probably the follow-ups rather than the diagnosis. And maybe we should not diagnose and treat on only on the OCT readings. We should consider along with perimetry and disc. But if we have one, I think we should use in all the eyes.
Right.
Piyush, there is a that virtual perimetry machine available. What are your thoughts on that one? I forgot the name of that machine. That
I
you
think
put a, that that VR
you mean the
goggles and then give the perimetry.
I there was some debate in the glaucoma groups also, but I think it's just to find out a scotoma.
So it will not replace this HFA,
It's
Humphrey
not.
visual field
Yeah,
analysis,
it's not going to.
or the other one.
Uh, but we need some beginning. We need to work on it. Someday it will work. but as of now, it shows only scotomas.
It's just a toy right now.
Not a toy,
No,
but
it is
I think
promoted. It
in the
is being
pipeline.
promoted as
Pipeline.
home perimetry. You know,
Yeah.
to sit on the perimeter for 20 minutes to do the perimetry is not possible
even
for
with
all
full
patients. Yeah, so home perimetry, if it can be achieved, then it can be. It's a good thing. Even lying down perimetry, for that matter, if not home. So,
Yeah.
provided it works. That's,
Provided it works.
yeah, yeah.
Yeah, just wanted to add something to that. As of now, it only, I think, has the supra threshold algorithm, and some of them have now started doing 24-2 also. The main shortcoming at present is that there's no progression algorithm as such. So you cannot track the progression of the patient on these machines as of now. If they can put in a good progression software and probably give you a similar analysis like the Humphrey, then maybe I think that this is the future of perimetry. The future perimeters will not be as bulky as they are right now. So this is probably the future, and this is a step in the right direction, but it still needs a lot of refinement. And also, I think we should wait and watch. It should not dismiss the machine because it may turn out to be a worthy replacement for perimetry in future. But as of today, no, that is definitely not. And you can like you mentioned, the advantage is that you can do it in the supine position. So for those neurological patients who cannot sit and do the perimeter, you can actually take it to the hospital where they are actually lying on their beds and do the perimetry if they are able to press the button. So that is something which is of an advantage. So as of now, it is definitely a step in the right direction, needs refinement, but I'm quite hopeful that it will live up to its expectation.
Yes, with the technology improving like it does these days, definitely there will be a good handheld home perimeter available for everyone pretty soon, I guess. Yes. On that note, I think we should shift to the second talk. I now invite Dr. Paaraj Dave from Baroda. He is a well-known glaucoma specialist practicing there for many years, and he would speak to us on the newer advances in medical management of glaucoma. I know there are a lot of things coming up, and he will tell us and guide us and what would be the right way to handle things in that field. Dr. Paaraj, please take over. We need to unmute Paaraj.
Sorry, I'll go again. So at the outset, I'd like to thank the Rajkot Ophthalmic Society for giving me this opportunity. And a big congratulations to Dr. Bharat also, who is being felicitated today. So my topic is newer development in the medical management of glaucoma. So let us start with it. So we all know that glaucoma is the main cause of irreversible blindness, and about 80 million people worldwide are affected by it as of the year 2020, and this number is only likely to swell to 112 million by the year 2040. Unfortunately, as of now, lowering the intraocular pressure is the only modifiable or controllable risk factor that we have in our armamentarium against glaucoma, and medications for intraocular pressure control definitely reduce the rate of progression. So basically, I'm going to divide my talk into two heads. One is dealing with the newer medication, and the other the newer drug delivery system. So let us start with the newer medications. So these are some of the medications that we would be discussing in brief in the subsequent slides. Some acting on the trabecular meshwork, some acting on the US scleral outflow pathway, and the others reducing the aqueous humor formation. So let us start with Nitrosodilol or the ROS kinase inhibitors, enhancing the trabecular meshwork outflow by inhibiting the trabecular meshwork Schlemm's canal cellular contraction. Additionally, they're also inhibitors of the norepinephrine transporters. So what it does is there is persistent alpha-2 receptor stimulation, decreased cyclic AMP, and a reduction in the aqueous humor formation as well. These medications have also shown to reduce the episcleral venous pressure, and an improvement in the optic nerve head blood supply has also been documented. in the US, this has been US FDA approved in December 18 in the year 2017 and is available under the brand of Ropreza by Aerie Pharmaceuticals, and it is FDA approved for once daily usage. So just some literature evidence on the efficacy part. So first of all, let us make things clear that it is slightly inferior to the normal prostaglandins, that is the LatinoProst, Tribodenal or the Bmoceran. And the study also did not meet the non-inferiority criteria for LatinoProst. And the IOP lowering in the Nitrosodilol group was 5.7 millimeter mercury versus 6.8 millimeter mercury with LatinoProst. And as far as the side effect profile is concerned, hyperemia was the most common side effect. Another important and interesting thing about the ROC inhibitors, especially Nitrosodilol studies, is that initially the first phase 3 trial, the ROCKET-1 study, actually did not meet the non-inferiority criteria versus Timolol. However, the ROCKET-2 studies met the criteria, and this led to the subsequent approval. But in this particular study, only those patients who had a baseline intraocular pressure of less than 25 or less than 25 millimeter mercury were selected. And again, hyperemia was the most common side effect. So this is in a nutshell the various studies associated with Nitrosodilol, and the common side effects in addition to conjunctival hyperemia include conjunctival hemorrhage and cornea verticillata. This is another, although rare but documented reported complication of Nitrosodilol, especially when it is used in edematous cornea. So in this particular case report, it was used to lower the intraocular pressure in a post-DSEC case. And what happened was that it resulted in formation of this typical reticular edema. So this kind of edema is typically associated with the usage of Nitrosodilol, and on discontinuation of this medication, the reticular edema disappeared. So this is again something that we need to keep in mind. You also have a combination of Nitrosodilol along with LatinoProst, and it is available under the brand name Rocklatan, and it was US FDA approved in the year 2019. The mercury trials demonstrated a superiority over each individual component. So the intraocular pressure lowering was greater by 1.8 millimeter mercury as compared to LatinoProst alone, and 2.7 millimeter mercury more as compared to Nitrosodilol alone. So as far as the Indian scenario goes, we have both Nitrosodilol and Riparsodilol, which are available to us currently, marketed and marketed by Ajanta Pharma. Riparsodilol requires a twice daily application, whereas Nitrosodilol needs to be put just once a day. I think most of our experience is quite limited as compared to the other medications that have been used for so many years now. In my practice, conjunctival hyperemia is the commonest side effect, and it is more of a problem with Nitrosodilol as compared to Riparsodilol. And the moment you start these medications, you definitely get a phone call from a patient that eyes have become very, very red. So that is something which you need to explain to the patient upfront. And as of now, they are not my first choice medication. My first choice eye drop medication would still be a prostaglandin. Moving on to the next, we have the latinoprostine bunod. So this is basically a nitrous oxide donating PGF2 alpha agonist. This medication is metabolized to latinoprost acid and butanediol mononitrate. So this acts by two mechanisms. One is increasing the UV scleral outflow, and the nitrous oxide part also relaxes the trabecular meshwork and the inner wall of the Schlemm's canal, resulting in increased outflow through the conventional pathway. Latinoprostine bunod is US FDA approved, available in the United States since the year 2017 under the brand name Vyzulta, and it has been approved for once daily usage. The side effect profile is similar to that of the other prostaglandin molecules. Studies regarding this medications have shown, the Voyager studies have shown that latinoprostine bunod is actually better than LatinoProst alone, and other studies have also demonstrated non-inferiority to Timolol. Another interesting fact about this medication is that the Jupiter studies that were done in Japanese patients, in this particular cohort, the patients had intraocular pressures, majority had intraocular pressures of less than 21 millimeter mercury. So even in such subset of patients, the intraocular pressure reduction was to the tune of 26.3%, which is fantastic. So this particular medication may turn out to be more effective, especially in patients who have normal tension glaucomas. And obviously the nitrous oxide moiety that is there will provide added benefit by improving the ocular blood flow as well. And the side effect profile is consistent with the other prostaglandin analogs. Moving on to the other drop medication, which goes by the name Tribodenal Sun. So basically, it is a highly selective adenosine A1 receptor agonist marketed by Inotech Pharmaceuticals. I mean, under research by Inotech Pharmaceuticals, and it upregulates the protease A and matrix metalloproteinase 2. It results in hydrolysis of collagen type 4 and thereby reduces the resistance in the extracellular matrix of the trabecular meshwork and improves the aqueous outflow. Now, there have been phase 3 trials with this particular medication, but as of now, it has failed to show any non-inferiority to timolol. That is, it has not been proved to be non-inferior to timolol. And again, hyperemia was the most common side effect. So as of now, I mean, we are not very hopeful whether this medication would reach us anytime soon. Moving on to newer prostaglandins that are also in the pipeline. One is goes by the name DE117 by Centen Pharmaceuticals. It is under development and is currently undergoing phase 2 trials. It is a prostaglandin EP2 receptor agonist, and this acts by reducing the cell stiffness in the trabecular meshwork and Slem's canal. And the efficacy has shown to be similar to the conventional other prostaglandins like LatinoProst, with hyperemia being the most common side effect. Another prostaglandin, again by Santen, is the DE126. Now, this is a dual receptor agonist. So it is a prostaglandin analog which acts on both the FP and the EP3 receptor. And this results in increase in both uvoscleral as well as the conventional outflow. Again, phase 2 trials are underway, have been completed, and phase 3 trials are now beginning. This molecule has shown to have shown a greater IOP reduction as compared to LatinoProst. In this particular study, the mean IOP reduction was 7.7 millimeter mercury versus 6.6 millimeter mercury in the LatinoProst group. Another newer prostaglandin by Ono Pharmaceuticals Japan is again, which is a dual receptor agonist, is the ONO9054. It is again an FP and EP3 dual receptor agonist. Again, phase 2 trials are now over and phase 3 trials have begun. And again, this molecule has shown to have a greater IOP reduction as compared to LatinoProst. Moving on to Bmoceran. Bmoceran is actually a naked double-stranded small interfering RNA. This blocks the beta-2 receptor via gene silencing, and this reduces the aqueous humor formation. The drug is largely limited to the ocular tissue, thereby eliminating any systemic side effects. Phase 2 trials have shown that it is non-inferior to timolol, and possibly we may get this medication sometime in future. Now we move on to the newer drug delivery system. So basically, what is the ideal drug delivery system? It is one where the duration of efficacy is long, preferably more than 6 months. It results in a 24-hour IOP lowering. The IOP lowering should be similar to or non-inferior to a prostaglandin analog and should have a similar adverse effect profile. It should also be a bioerodible system in order to minimize the need for removal of that particular sustained release implant. And also installation or injection should be an in-office procedure with minimal operating room time. So we'll start with discussing periocular inserts. So we'll start with the Bmoceran ring. So this ring is a 24 to 29 millimeter diameter ring which rests between the eyelids, and it has Bmoceran embedded in the silicon matrix inside. And this provides a sustained release of prostaglandin, which gradually reduces with time, but comparable levels of Bmoceran are released as comparable to the drops for as high as 180 days or 6 months. So this is how the ring looks like. This is how you insert it inside the eye. It doesn't look very convenient for use, but it is definitely one of the options. Studies have shown that it results in sustained release of Bmoceran for up to 6 months, and non-inferiority to timolol, however, has not been achieved. So in one particular study wherein Bmoceran ring versus teardrops were compared with a placebo insert ring and timolol, and this particular study showed that it was non-inferior to it did not achieve the non-inferiority with the timolol group. However, the ring was in place in 88.5% of the patients even at 6 months, And of all the dislodgements that happened, all were very promptly noticed and identified. Side effects profile and discontinuation rates were similar in the two groups. And therefore, again, this kind of insert inside the eye, which is not very convenient, is unlikely to find many takers even in future. Another device is the topical ophthalmic drug delivery device, or the TOD. So this is being developed by Amorphex Therapeutics. Now this is a flexible device which floats on the tear film concealed under the upper eyelid. Phase 2 trials have been completed, and by using timolol as the drug in these reservoirs, and it has demonstrated safety, efficacy, comfort, retention over a period of 180 days. And this can also be used for other ocular disorders which would require chronic therapy as well. So this is something which is very promising. Moving over to the punctal and the canalicular plugs. So this particular plug, TriboProst plug, which is developed by Ocular Therapeutics, is basically a TriboProst encapsulated in a resorbable hydrogel rod. And it is to be placed either in the superior or the inferior canaliculus, and it is fluorescein incorporated to enable visualization and detection. In this particular study, wherein 26 plugs were placed in 17 patients, the IOP reduction was to the tune of 24% on day 10, and this gradually diminished on day 30 from the baseline. Epiphora is a troublesome problem that happens because you are occluding the puncta, and the retention rates are also not very great. So the phase 2 studies in this particular study has shown that when such punctal plugs plus tear substitutes were compared with timolol plus non-drug eluting plugs, so what they found out was actually timolol plus no drug plugs performed better. This is possibly because of the longer retention of timolol due to the punctal occlusion. So again, not a very promising method of drug delivery, and the retention rates as the days progress, they go on reducing. So that is another problem. You also have LatinoProst punctal plugs being developed by Mati Therapeutics. Again, these are in phase 2 clinical trials, and Epiphora continues to remain a limitation. Moving on to the anterior chamber implant. So this is available in the United States and goes by the brand name Durista, marketed by, I think, by Allergan, and possibly soon will be coming to India. So this is the polylactic co-glycolic acid copolymer matrix. That is the Novadur platform, on which we are actually, the retina specialists are using the Ozurdex implant. So this is the same platform. So this is an intracranial injection which uses 28 gauge applicator system, and this sustained release implant has to be released into the anterior chamber. Studies have shown that IOP lowering is pretty similar to the topical BMoceran group. And the studies have shown that, and the effect of this implant lasts for at least 12 weeks, at least 3 months. And the common side effects which have been noted are hyperemia, foreign body sensation, eye pain, lacrimation, conjunctival hemorrhage, and punctate keratitis. It will be interesting to see whether side effects like lash elongation, periocular pigmentation, and fat atrophy are lesser with the sustained release implant as opposed to the usage of the medication drops. However, on the flip side, we may also see that side effects like iris pigmentation, uveitis, and possibly cystoid macular edema may increase with the use of this sustained release implant. So this is how the implant looks like. It's a very small implant. This is the applicator system, and this is how the implant looks inside the anterior, angle of the anterior. This is the inferior angle. This is how it looks when it is inside the eye. So like we said, it has already been FDA approved. It has shown to be non-inferior to timolol, and 12-week data they have shown that there is a sustained 30% reduction in the intraocular pressure. One interesting feature in this particular study was that after 3 treatments, 80% patients did not require any further treatment for another 12 months. And this was explained on the basis that this implant causes a sustained reduction in the episcleral venous pressure as well. So there's something which is, to be experienced, to be looked forward to in India as well. You also have other intracameral implants that are under works. This one by Envisia Therapeutics. Again, comparable IOP lowering with our prostaglandins has been shown with no serious adverse effects and no change in the endothelial counts or the corneal thickness. You also have another iDose sustained release implant, which is based on the platform similar to iStent, which is used for MIGS, not available in India. It's a titanium implant, and the drug elutes through a membrane cap. It is anchored, the anchored portion of the implant is advanced through the trabecular meshwork into the scleral tissue, where it remains and results in sustained release of the medication. And once the drug depletes, the implant has to be removed and replaced. So the main concerns with the use of intracameral implants are that these are, they are invasive procedures, and injection problems, injection side effects will always be there. There will always be difficulty to explant if complications arise, and there are definite concerns regarding the effect of such implants on the corneal endothelium. Moving on to the subconjunctival implants, you also have some companies who are working with, working on this subconjunctival implants for sustained release of medication, but there are a lot of limitations as far as subconjunctival injections are concerned. And these include, they incite a local immune response when they are injected subconjunctivally. And the release is also not linear, and our understanding of the scleral permeability is lesser as compared to the corneal permeability. And also there will be need for operating room requirements. So this may not be a very popular option, but we don't know what the future holds. Maybe they'll come up with something good here as well. Moving on to the last subgroup, that is the miscellaneous group. So you have certain drug eluting contact lenses which are under development, under refinement. And you also have microdose sprays which look similar to this. They use piezoelectric crystals to dispense the medications. So you can directly dispense the medication in an upright sort of a head position, and there is also less steering. So this is something which may come up in the future. You also have bioadhesive matrices under development, which will stay on the ocular surface for an extended period of time, providing sustained reduction in the intraocular pressure. Another important, interesting thing which is under possibly will come in future is the usage of intravitreal brimonidine. Now, this particular drug is actually under study for reduction of geographical atrophy area in age-related macular degeneration. And as a corollary, it may also show to reduce the intraocular pressure as well. So maybe you'll get an intravitreal implant of brimonidine as well as in the future. So a lot of things which may turn out in the future. So to conclude, I'd like to say that new medication eye drops, always welcome, always, it is good to have new things in our armamentarium against glaucoma. However, the basics like, how to install the drops, spending adequate time with the patient, showing how to, put the drop, doing punctal occlusions, not, putting two medications one after the another, waiting for 10-15 minutes between any two medication is something that those basics will always remain, and you'll have to, explain everything to the patient in order to have the maximal effect of the medications, the drops. Implants, they have the potential to dramatically improve the compliance of the patient. But patient attitude for implants may not always be very forthcoming, but implants are actually drastically improving, and maybe in the future we'll have the ideal, sort of an implant which will tick all the correct boxes. The search for the ideal drug delivery system is still on, but hopefully we'll reach there sometime in future. And novel innovations have the potential to definitely reshape glaucoma management. And we hope to see many new things coming out in the future. So with this, I'd like to conclude. Thank you so much for your patient listening.
Thank you, Dr. Paaraj Dave. Excellent talk. Lot of new medications in glaucoma with a lot of new devices to deliver the drug. Probably glaucoma is one field where pharmacology is at its best. Newer and newer molecules, tongue twisters also probably. Now, we now have many drops which work OD once a day, 24-hour. So what is your take on the duration of action of these drops? Are they reliable to work for all 24 hours throughout the day?
Absolutely, absolutely. All these medications have been tested extensively as far as their the peak effects and the overall duration of action. For that very reason, prostaglandin remains the drug of choice because of the convenience it gives us. and a favorable side effect profile as well. So those are the medications which have least systemic side effects. Redness, lash, elongation, pigmentation are some of the local effects which we need to be careful about. Those patients who have a past history of herpetic infections, etc., it's all contraindicated in such patients. But most of the times you want to start with the prostaglandin because they are the best medications that are currently available, and everyone should start with the prostaglandin medication.
So is it that what we learned in our PG days long back, the first line of drug has shifted from beta blockers to prostaglandins?
Absolutely, unless contraindicated, unless you are dealing with, even in inflammatory glaucomas, if I think as a desperate last ditch effort, you may also use prostaglandins even in such cases. But neovascular glaucomas, inflammatory glaucomas, you possibly want to avoid prostaglandins. But I think other than that, whenever possible, whenever not contraindicated, always start with the prostaglandin analog. It could be either of the three, whichever you are comfortable with. Almost all are equally efficacious, not much difference. Side effect profiles and whatever you are more comfortable with, you should go for that particular molecule of prostaglandin, but definitely start with the prostaglandin.
Right. And these drug
Dr.
delivery
Dave.
systems, have you tried any of these newer drug delivery systems? Are they
No, they are
available?
actually yet to be, yet not available in India, but the Bmoceran sustained release implant, we'll definitely get it sometime in the future because the United States has already started using it, and it is available under the name Durista. So that we are actually extremely hopeful to get it in the next 1 or 2 years. I think Allergan people will be in a better position to tell us the timeline, but I think they will bring it to India pretty soon. So that is something to look forward to in the immediate future.
Right. Harshal had a question.
Dr. Dave, I wanted to ask, normally in a single day medications, suppose we are talking about prostaglandins, we tend to put them at night, we tend to instill them at night.
Right.
But considering that the spike in the IOP occurs commonly in the early morning or in the afternoon, should it not be that these drugs should be placed in the morning rather than at night?
So basically, the peak effect of the prostaglandin, it happens 12 hours after you put the medication. So most
Is justified.
Sorry?
That is justified. Prostaglandin is justified. But for timolol, for example, they say timolol OD once a day.
Yes. So basically, the timolol OD it's a gel formulation. So what they have done is that they have made sure that timolol remains in the eye for a longer time. And they have shown that the IOP lowering is similar to the normal timolol that you put twice a day. Having said that, you generally want to use timolol in patients who actually are ocular hypertensive or who actually don't have glaucoma. So even if at the end, the fag end, even if the control is a little off, then you are still not very bothered because you're not very aggressive in treating those patients as such. But the studies have definitely shown that the efficacy part it remains. It is efficacious in lowering the intraocular pressure for the entire duration of 24 hours. Another important caveat is while using timolol as such, or the gel formulation, is that you want to basically avoid using it very late in the night, because as such the aqueous formation is at its lowest in the night. So what happens is, even if like you said, even if the gel formulation is not very effective at the end, so if you put one drop in the morning, in the night as such, also the aqueous humor formation is at its lowest levels. So you may not actually require that kind of a concentration at the end of that particular effect as such. So maybe that is the reason why the gel formulation also is equally effective as compared to twice daily instillation, because if you put it in the morning once a day, and evening, if you don't require that much concentration of the drug as such to reduce the aqueous humor, probably that is the reason why the results are such that the effect part is similar. So always use timolol in the morning, and even if you're using twice a day formulation, ask the patient to not use it very late in the night, because then there is no point. So 7 in the morning, 7 at night, or maybe 8 in the morning, 8 in the night, and after that there's probably you don't want to tell them to put one drop at 10 in the evening and 10 in the morning. That is something you want to avoid.
Yeah, that's a very good point.
Okay. Yeah. Thank you, Dr. Dave. Thank you.
Welcome.
Yeah, we learned a lot of points. Sir, Kadre sir.
Mukesh.
Yes, sir.
Yeah. It was excellent talk by both Piyush and Paaraj. We did learn a lot about the advanced drug delivery systems and all. I just had an observation and then a question for both of them, and their comments as well. I would welcome. In the past, if you remember 20 years back, we used to operate patients for cataract when they were little advanced than what they are today. So they used to be operated a little late in life. Now what has happened is at very early stages of cataract, they are operated. So maybe they are maybe in their 40s or 50s. And then the general impression is that once you operate a cataract, and then it's all right if they come once a year or they do not come for follow-up for years together. Recently, what I have observed is patients, especially who had a family history of glaucoma, but they didn't have glaucoma when they were 50. They have been operated for cataract. And when they start seeing less, say at the age of 70 or 75, they come to you, they have pseudophakic glaucoma with quite advanced disc changes. The vision may be 6/6, but when you do their fields, you examine the disc and all that. So sometimes, you don't have any option but to operate on them to reduce the intraocular pressure. So now I have realized that pseudophakic eyes need to be observed closely for glaucoma, especially if they have a family history. And therefore, all cataract patients, even if they do not have glaucoma, you must ask them a history of glaucoma in the family. That is what I have been observing for the last 2 years or so. And I operated at least 3 patients who have pseudophakic glaucomas. But the good thing is that because you do a temporal incision, the superior part is all virgin and therefore they do well. I would like to know their opinion about this because people tend to particularly miss this diagnosis, or they would feel that there is something like ARMD or something. But glaucoma is is not considered in very advanced stage of patient who is pseudophakic, good pseudophakia, but losing vision. The second thing, I would finish my year and then take the response from both, is that you get a lot of patients these days who are on maximum medical medication and controlled. The glaucoma is controlled and they come for cataract. Now, we all know that LatinoProst should not be used after you do cataract surgery. So prostaglandin analogs are stopped for some time. Now, the question is that once, say, after 2 months, they do not have any inflammation, the eyes are fine, can we restart LatinoProst in these patients, or we have to, use other drugs that are available at our disposal? Please, comments from both Piyush and Paaraj.
Sir, your first question, I take it as that you are telling the patient who had a family history of glaucoma, who underwent cataract surgery are at more risk, or any pseudophakic eye is at more risk.
We really don't know whether it is the first time glaucoma is appearing in a patient, but because they have been operated early, they didn't have glaucoma then, but then it appeared 20 years later. So there could be both types. There is a family history and there are patients who are, say, first timers. So both types have been seen.
I think probably the glaucoma may appear naturally. In that case, anyway, it's going to appear at 60 or 70 years of age. So maybe only one thing I would say, that all, whether pseudophakic or cataractus or clear lens, they have to get a routine eye checkup maybe every year. They not only glaucoma, they can have any other disease. I always tell my patients that I'm treating your cataract or glaucoma, whatever, but I can't guarantee that you don't get a retina problem in future or any other eye problem in future. So come for yearly checkup, go anywhere, but get your eyes checked once in a year. One thing, additional thing I would like to say, because that cataract part is been discussed. I find early cataract surgery is being done nowadays, and I think that is helping us to reduce the number of PSCG patients, which were more in the past because the cataract were operated less. So I think, and third thing, all pediatric cataract operated should have a lifelong follow-up, and they should be warned that you may 20% chance of getting glaucoma in future. Paaraj?
Absolutely, I agree with the fact that follow-up is the key, and even if it's just a cataract and you are done away with the cataract, you should not forget the patient. Follow-up is the main thing. This is important to note that the trabecular meshock outflow will go on reducing with age. Even if you've done the cataract, the outflow is going to reduce with age. So the patient will definitely, and any patient will be at a risk of, he may or may not develop glaucoma, but the outflow definitely reduces. Another thing about family history, although family history, it is good to ask and good to keep them under surveillance. However, family history is something which is not very absolute. So you can have a person who has a family history and not have glaucoma. You can also have a person who has no family history and a glaucoma. So again, it is just the regular follow-up which is absolutely essential. Commenting on the second part of the question, in those patients wherein you have just controlled the intraocular pressure with maximal medication, I personally may choose to not stop prostaglandin even for the cataract surgery, for the fact that cataract surgeries have evolved a lot, and modern day cataract surgeries induce very little inflammation as such. So the risk of developing CME, etc., and increased inflammation is pretty low. However, if you want to stop, you can definitely stop and start temporary, say an acetazolamide tablet for the time duration of at least 6 weeks, if you want to go by the book, because that is the time which is required for the blood aqueous barrier to actually completely heal. So maybe after 6 weeks, you can definitely you can restart a prostaglandin. There is nothing against restarting it. You can easily restart and stop the Dimox or acetazolamide after that. But if you have barely control the pressures, you may choose not to stop. I don't think it makes a lot of a difference, though we don't have very substantial data regarding what happens if we don't do or what happens if we do, but it's a personal choice. And I think that is there. And obviously the intraocular pressures are going to go down a little when you do a cataract surgery, more so for angle closure eyes as compared to open angle glaucomas. But a combination of a possible reduction in pressures with you substituting or adding oral acetazolamide for the time being should be okay for most patients. Especially if it's an angle closure case, you will find that the IOP lowering may be even more than what we expect. So, but nothing against restarting prostaglandins. You may do so after a period of 4 to 6 weeks.
I would like to have a line on the second question Dr. Gadre asked. What I do personally is that I don't stop prostaglandins pre-operatively, but definitely I don't start it post-operatively for a month. So, and what Paaraj said, I would like to give Dimox when I want to stop prostaglandin. So post-op 1 month I'm not giving.
It's just a thought that we don't give Dimox to these patients. We give other anti-glaucoma medications that are available. Let's say brimonidine.
I think you said it was already on maximum medication. Yeah, maximum medication.
That's right. That's right. That's right. But as you said, with cataract surgery itself, the pressure goes down a little. And if you add, say, 1 drop, and if it works, so that controls the pressure instead of giving Dimox, maybe for a few days, and it is all right. So that was the whole direction of the question. Anyway, thank you very much for your comments. Thank you. Thank you.
Thank you, sir.
So if we do not have any question,